And I know we didn't discuss this earlier, but I know it's a question that comes across our desks a lot from folks who are diagnosed with small cell lung cancer, whose cancer has metastasized to the brain, and PCI, or prophylactic cranial irradiation. So radiation to the brain, the whole brain radiation in a prophylactic sense, which historically, well, I'm not going to tell you. I'm going to let Dr. K tell you.
It's been an area that's fraught with controversy or differing opinions. And, historically for patients that had limited stage small cell lung cancer, who didn't, by definition, didn't have brain metastases at the time of their diagnosis, but successfully treated chemoradiation, the risk of failure in the brain, of eventual metastasis to the brain, was considered to be so high that you would scorch the earth, for lack of a better phrasing, and try to eradicate any microscopic disease that might be there, that might be subclinical, and prevent brain metastases from arising. And it's quite effective at doing that. It's quite effective at eradicating or eliminating the risk of brain metastases in a significant proportion of patients. But it comes at a cost. Radiating the entire brain, especially doing it prophylactically for somebody that doesn't have brain metastases, is not without controversy because there are toxicities that come with that, right? Patients can have long-term memory loss, for example. And so the field had shifted, I would say, increasingly away from prophylactic cranial irradiation and more to surveillance with MRI. And now, recently, with some of the analyses from the Adriatic study, the pendulum is starting to swing back because there seems to be a signal for patients within that Adriatic study we mentioned earlier, for the patients that got immunotherapy, that maybe the patients that get the PCI are doing better. Maybe they're living longer and having a longer progression-free interval. And so I think we're gonna start seeing more PCI deployed, but it should always be a conversation. This is not, whether to start chemotherapy is barely a conversation, right? Unless the patient is focused solely on end-of-life care, you should give them chemotherapy. Whereas PCI, I think, is a much more nuanced conversation where you discuss the pros and the cons, the alternatives. And with that, I think it's important to distinguish limited stage from extensive stage, because even when I first started treating small cell lung cancer, PCI was still being offered to patients with extensive stage small cell lung cancer that didn't have brain metastases. And more recent evidence suggests that might be flawed, that those patients, while they may have less risk of brain metastasis, they may suffer disproportionately greater toxicity that outweighs those benefits, and may actually live a shorter period of time as a consequence of that radiation. And so for me, I think limited stage small cell lung cancer at least deserves a conversation about PCI with some equipoise between PCI and close surveillance. Whereas extensive stage small cell lung cancer, I think, should be a conversation primarily around surveillance of the brain outside of a clinical trial.
So I'll be brave if you're brave. I'll be brave, but only